Dr. Nadeau, can you just start by introducing yourself, and then I will let the questions pour in here, and then I'll relay them to you.
Sure. First of all, my name is Kari. You can call me Kari. I feel terrible that you've all waited and that I cannot somehow connect with you. I'm so sorry. My cell phone number is 650-867-4592. And please feel free to call me anytime. I really feel terrible that it's late and you should be with your families, and I'm happy to answer any questions that you have. I will try to do that on the commentary, but I don't see questions coming up on the commentary, so I'll try to work with Weston.
So I do have a question here, Dr. Nadeau, and it is, my 9-year-old is still avoiding milk. She has symptoms of itchy mouth, upset stomach, vomiting when actually ingested at school. Her allergist believes she may outgrow this allergy by middle school, but her numbers are still too high to challenge. In your opinion, do children this age still have a chance of outgrowing this allergy? Any hope that she will outgrow this or be treated?
Yes, I understand and I sympathize because, of course, as parents, we all hold out the hope that our children will lose disease, or in this case, milk allergy, because it does tend to be an allergy that people outgrow, although that's becoming less and less the case. And you should talk to your allergist, but given a clinical history and given specific IgE to milk, if it's over a certain amount and your child is older than 5 years of age, then most likely she will not grow out and would be a candidate for immunotherapy, possibly.
Excellent, thank you. I have another question here. It says, my son is ANA to milk, casein, and whey. He is 8 now, and his numbers have dropped from over 800 from over 100 to 30 IgE. Should I wait for him to possibly outgrow, or should I jump to OIT?
Casein and whey are difficult. There are a lot of different, I think milk allergies are some of the worst allergies to have, obviously, because there are a lot of dairy products, and across the field of people with milk allergies, there are a lot of different proteins to be allergic to. And so I think that it would be very appropriate for your son to get specific testing for those proteins. And if they're greater than around 10 or 12, and I talk about this in the book, then most likely it would be great to get immunotherapy. And there are a lot of different options now. There's nothing approved by the FDA. It's always better to get something approved by the FDA. But if you do have a research center near you, there are many clinical trials going on in milk allergies now.
Excellent. There's actually, obviously, this is a lot of milk allergy groups. So there's a follow-up here with a difference in age, basically from 8 to 19. So is there any hope for 9-year-olds, any developments to treat someone with trace with
reactions even to trace amounts?
Absolutely. There's absolutely the ability to treat. We've treated 3,000 individuals at Stanford in clinical trials, and everyone that stays with the program can improve, and we make sure that they get personalized treatment to help them.
Excellent. Thank you. How does Xolair help with food immunotherapy? What are the side effects? That's XOLAIR.
I don't know how to pronounce.
Yeah, no problem. So Xolair is a drug called anti-IgE, and it's helpful to give in conjunction with milk immunotherapy. That's one of the first studies we did, and I talk about that in the book. So it's not for everyone though, and it's currently in clinical trials, so it's not available for food allergy. It's best to use FDA-approved drugs.
Excellent. Could you actually talk a bit about early introduction strategies for milk?
Yes. I really do work a lot with people to prevent allergies as well as to treat them. And so with that in mind, I wrote a lot of the book about what could be the potential causes of food allergy. And one of the potential causes is that we're not diversifying the diet early enough. And I want to make sure that everyone, of course, I appreciate different diets and different cultures, and that's very important, and breastfeeding is very important as well. However, it is clear that in those cultures that feed their children a diverse diet of whatever they're eating at the table, as long as it's not chokeable, as long as it's not honey, that really does improve the child's gut over time. So feeding early and often is probably better. There are many studies in Israel, for example, in which children, infants, if they were fed cow's milk early, they were able to decrease the risk of milk allergy.
Thank you for that. So there's a follow-up. My son passed a baked milk challenge. He eats only a few baked milk items and refused to try new things. We didn't want to force it. Wasn't able to bake cupcakes. A few months later, we tried to feed him baked milk food. Even the baked food he previous was successful with, and he reacted with itchy mouth, tongue, bellyache. This is a common theme. I think you could speak to Kari. The question is, was it my fault I didn't consistently keep baked milk in his diet for a few months? And how common is it for a child to go backwards and outgrow their allergy?
Yeah, first of all, as parents, we put ourselves through a lot of guilt trips, even though we try not to. And so I want to reassure the parent that's asking that it's not your fault, that baked milk can be highly allergenic. We have to be very careful. The child that's allergic to baked milk is oftentimes one of the more severe milk allergic individuals, and they have a much lower chance of growing out of milk allergies. So with that in mind, you did nothing wrong. You tried your best. And in that, we need to try to help you with getting better therapies for food allergies. I think that in my course of trying to take care of families with food allergies, especially milk allergies, parents feel very alone, and the children feel very alone because it's such a tough allergy to have. And a lot of people focus on peanut allergy, and that's important, but many people have egg, milk, other allergies, and we need to focus on them as well.
Thank you. So there's a question here about my son is 7 now and still ANA to dairy. We attempted 9 months of OIT when he was 4. We made very little progress, never getting past 5 milliliters. Have you had patients attempt OIT a second time and succeed after failing it the first time?
As long as people stay in the program. Now, the problem is while you're doing milk immunotherapy, you can have reactions. And in the book, I'm very careful to say, let's do FDA-approved drugs. There are many FDA-approved drugs, and we need many options for patients. So if you failed one particular option, just like if you were going to a doctor for another disease, if you fail one therapy regimen, you try another. And so we need more options for children and for parents. And I have treated people at any age. My oldest patient that I treated for food allergy was 99 years old. So I believe this is possible at all ages, but importantly, you should do it in a doctor's office with trained individuals, with a board certified allergist there. And that's very important to ask a lot of questions if you do decide to undergo immunotherapy. It's not for everyone. And I think there are patches now going on in the skin. There are other ways to try to improve food allergy and to decrease the risks of having additional food allergy for anyone that has food allergy already. And those are what I talk about in the book. But I want to make sure people know that oral immunotherapy is very tough. As long as you stay with it, and as long as you don't get any side effects that are severe, I do believe it's possible for everyone to get to a better place.
Is there a specific number that you would travel casein and weigh IgE values? Would you do a big to milk challenge at?
Yeah, I think a lot of us want to look to those numbers as if they are the threshold to use, but unfortunately they are not. A lot of the specific IgE testing for milk especially can be wrong 50% of the time. So we must add in clinical history as well as skin prick test history. And if you've had a food challenge, that also helps us know when someone should get immunotherapy versus when someone should possibly think about their outgrowing their allergies. So all of these things play a role in being able to see what the milk allergy is for that particular patient. But it's more than just numbers in a blood test. Because unfortunately, the IgE only represents the tip of the iceberg of all the allergic molecules. We call them biomarkers. There are so many more biomarkers that play a role in mediating anaphylaxis to milk. It's not just IgE. So that's why we need to look at the whole person and complement all of the tests. So no one should just be dependent upon one test.
Excellent advice. There's another question here. Do we know why those with milk allergy are 3 times more likely to need more than 1 dose of EpiPen?
Yes, that is a very good question. I think there are several reasons. One of my thoughts is that people need to take milk allergy more seriously. A lot of people, and I know this family group does, I know that you all will agree, that milk allergy, a lot of people think they have grown out of milk allergy when they're older than 5, but that's not always the case. In fact, it's harder to do that. So people with milk allergy sometimes think that they've outgrown it, but that's not true. So they still need to carry an EpiPen. I also think that dairy is everywhere and that there are so many unknown items that have milk in them, like toothpaste, like certain medicines. And so with milk allergies, there's a much higher chance of having anaphylaxis. People do labeling for peanut now, but labeling for casein and whey, and I've worked very hard to try to change these labeling laws with the FDA, and I'm glad that the previous administration in the federal government did change the labeling laws, but we have a long way to go. And I think the third reason is because milk proteins are really complex. When you bake them, when you have them in different features, and people are allergic to many different proteins in milk. And so to me, that's the third reason why people with milk allergies have a higher chance of needing an injectable epinephrine device. So please know that I feel for you. This is a very tough allergy, one of the toughest ones, and we need to help each other out and explore these issues. And I'm happy to help out and be a voice for all of you to try to make sure that milk allergies are treated better.
Excellent. Is there or is oral therapy for milk more difficult than for other foods?
I think that because milk has such a variety of proteins, and because foods that have cow's milk in them also have a variety of different proteins, cheese versus yogurt versus milk itself. And then in addition, people try goat's milk and cow's milk and different animals, and they're all very similar. So I do believe that when giving immunotherapy for milk, we need to make sure that whatever milk product we use to treat someone, it has to encompass all those proteins. And making sure of that means that someone needs to know biochemistry. We need to really make sure that we naturally give back someone all of the baked type proteins and the unbaked proteins in milk to give a full complement of all the possible proteins that that person needs protection from with immunotherapy. And that's what I worry about is when we get an FDA approved drug, I think that's what it's going to take. Because right now, if you go to other clinics with immunotherapy to milk, you might not get the full complement of proteins that are needed to protect you or your child.
Awesome. Thank you for that. I have a question. Thank you, thank you. I have a question here from the Hardwicks who ask, can you explain how immunotherapy works for someone with a high milk sensitivity, IgE over 100?
Yes, thank you for that question. I see the Hardwicks, thank you, Mr. and Mrs. Hardwick. So yes, we very frequently treat over 100, milk, egg, other allergies too. We specifically want to help the people that are over 100 that have had prior anaphylaxis that has been severe, because I feel like those are the people that we want to make sure do not have reactions to small amounts of milk. And with that, I want to be able to help you know that it is definitely possible. We start very low and very slow. And so with milk, we'll start with 1 milligram and we'll go up very carefully to a higher amount. With milk, an accidental ingestion can be as high as 1 gram, which is about 1 ounce of milk. So when we do our milk immunotherapy, we want to protect up to levels that are much higher than nuts, because a dairy accidental ingestion is much higher than a nut accidental ingestion in terms of milligrams of protein. So yes, it's possible. Yes, we've done it before. And yes, we do it very carefully, and not just Stanford, but also many places around the country. Johns Hopkins has a great example of good milk immunotherapy that they've been very successful with. My colleagues in Spain and Italy also have good programs that they've been using. So I want to make sure you have the hope and promise that hopefully soon, just like the FDA approved a peanut therapy, hopefully we'll see milk therapy come to our doorsteps soon. But make sure that it's FDA approved and something that has gone through a lot of rigorous testing to make sure it's safe and effective.
Excellent, thank you for that. They have another question, which is, if a pill has a lactose binder, is it dangerous for a person with severe milk allergy?
Great question. I talk about the lactose versus proteins in milk, and I'm sure many of you are aware, lactose is the sugar that milk has. And most importantly is there are rarely any milk proteins in lactose. However, we have to be very careful because people with milk allergies can be allergic to the smallest amount of milk protein. So you can't necessarily trust a label like you would want to. So I would recommend calling the company and making sure that if they're going to say it only has lactose in it, that they also tell you whether or not there's any possible milk proteins in the pill. If it says solely lactose, then I think you can know that that is true. Because if it's a drug pill, then under law, they have to talk about all the other ingredients. But if it's a food, they don't necessarily have to. So it's important to call the company and ask whether or not there's milk protein in those items. And of course, all of you know very well between a food sensitivity to milk with lactase deficiency with lactose intolerance, and milk allergy, which can lead to anaphylaxis. These two things are very different, and I talk about that in the book because people should not think that a milk allergy is the same as milk sensitivity.
Awesome, thank you. Is there a way to tell who is not a good candidate for immunotherapy?
I think one of the items that we use is really the mindset of the family, that no matter what the biology is, we've been able to show that this has been effective. But if the mindset of the family is one of fear or trepidation or hesitancy, then it's very hard to go through. I would never want to force a child to eat something they don't want to. So one of the criteria we like to use is making sure that the child and the family want to do this. Because if they don't want to do it, then we should not start. They need to know that it takes time, it takes energy. They might have mild reactions through that. And if someone is fearful of those reactions, it's not worth going through because it can really cause some anxiety, and I would never want that in a child or in a patient who's an adult. So you really have to think through it, talk to the doctors, make sure that they tell you all the possible choices that you have. But many of my patients who are milk allergic are very happy that they went through it, because they at least have the peace of mind that they can have milk containing products that it might not be a cup of milk, but at least it is a product that they couldn't eat before, that they were afraid of eating before, but they went through the therapy, so at least they don't have to worry about accidental ingestion. So I think for those people that have that type of mindset and they really want to work through this to get to a level where they don't have to worry about accidental ingestion, it's worth doing. But there's no age, there's no IgE number that would preclude someone from being able to get therapy. Does that help answer the question?
I think it does. I have another question here I think is going to have a lot of interest inside this group, and it's, are there any FDA products in the pipeline for milk?
There is a milk patch that is made by DBV, and that has a lot of hope and promise, and hopefully they will meet their threshold for the FDA approval process. We don't know yet, though. It's currently in what we call phase 3 trials. So we're waiting, and I hope that it is approved. There's another product that's currently in a beginning stage that it has milk and other foods as well, so that you can also get a desensitization to other foods in addition to milk. So it's a multi-food allergic therapy, and that's very exciting too.
Awesome. Yeah. Definitely sounds exciting. There's a question here. I was told my son has a milk allergy. Does this mean only cow's milk or other milk as well?
That's an excellent question. So cow's milk is very related to goat's milk, is related to other types of milk by mammals, but not horse, not mare's milk. But it's very hard to milk a mare. So I would be very careful that if you have been diagnosed with a milk allergy, to know that you should really avoid all mammalian milk for the most part, because there's a lot of cross-reactive proteins.
I've heard that 80% outgrow milk by 16. Is this true?
It used to be true. 10 years ago, that was true. But it is no longer as true. That nowadays, it is more unlikely to lose your milk allergy. We just did a large study that we published 2 years ago showing that it's the case that more and more people with milk allergies as children are not losing them. And we think that's due to a variety of environmental factors. And I talk about those in the book. And there are more and more adults with new onset milk allergies as well. And the other thing that milk allergies is associated with is eosinophilic esophagitis. And that's also rising in our country. It's not because we're getting better at diagnosing these milk allergy diseases, it's because they are actually increasing. They are what we would call an epidemic.
Yeah, some of that was fascinating. Thank you. So there's maybe one final question here as we're kind of closing out the 30-minute allotment. And that is, what is the success rate of milk immunotherapy in your clinic?
For everyone that goes through milk immunotherapy and stays with the program and drinks their dose of milk or eats it every day, they have maintained desensitization. They can have mild reactions over time, but they don't have the capacity for anaphylaxis any longer. So we tell people to still carry an injectable epinephrine device, but many of the people that have been through this have done very well. However, sometimes when they have a mild reaction, they'll stop the therapy, or if they have abdominal pain, they'll stop the therapy. And that's when people can go off the track and go off the road, and then it's hard to get back on the road. And so I think about 20% of patients will have abdominal pain and leave the therapy regimen, but 80% do not. And so those 80% that stay on the program do get a lot of benefit from the program.
Well, that's wonderful. Okay. There's maybe one final question here. Are there any studies that show what could cause a newborn child to have a milk allergy?
Thank you. We do talk about that in the book, that there are about 5 different causes of food allergy for newborns. It's nothing you did in pregnancy. It's nothing in your genetic tree. 2/3 of children have food allergies without any family history at all. And so there's a variety of things like diversity of diet, making sure that there's no dry skin, making sure that vitamin D levels are good, making sure that there's diverse microbiome for the child, and making sure that they can grow up with animals in the house. It actually does help if you're not allergic to animals. So there's a variety of things that one can do to decrease the risk of food allergy, milk included.
Awesome. Well, thank you, Dr. Nadeau, or Kari, as you said at the top of the chat to call you. There's been a lively chat going on here on Zoom, so thank you everyone for participating in that as well. Is there any last words you'd like to say, Dr. Nadeau?
I want to thank everyone, and I do hope that you'll like the book. Please let me know. I love honest feedback, and the book has all the science and a lot of the myths about food allergy. We do have nice, succinct sections on myth busting and making sure we understand what we understand and what we don't understand. We're very honest about. In addition, in the website, we actually have real-time updates to any knowledge about the book and any science. So I would love for you to let me know how you like the book. We have a lot of references in there for moms and dads and patients. It's for all ages and those with and without food allergies. So I hope you enjoy it, and thank you so much for your time. And I apologize for those of my colleagues on the East Coast that it's so late. So I hope you have a very good day tomorrow. Thank you for your time.
Awesome. Thank you so much.
All right. We have Jill saying thank you. We have Ashley saying thank you.
Okay.
Lisa Klein as well chiming with thank you.
Thank you, Lisa. I know you have surgery tomorrow at 5 a.m., so kudos to you. All right. Well, thank you very much, everyone. I hope you have a good night, and I really mean it. Call me if you need anything. I'm happy to give general information. Thank you.